practical points as regards to giving general anesthesia. This is how I would tell my juniors, and this is how the seniors have taught me as well. Basically, the bare essence of how a general anesthesia is to be given. Before you even go to the patient, you're first going to check the OT, check if the machine is alright, if there are emergency drugs, if the scopes are alright, if the suction is working, if the ambu bag is working, if you have all the drugs you need for the emergency for anesthesia, if the table is working. Firstly, you'll have assessed the patient in the pre-anesthetic clinic or the previous day of the surgery in the wards. So on the day of the surgery, when you see the patient, you identify the patient by name. So which procedure is undergoing, which side, if there's any side, have you asked for any investigations, and what are his medications, that has he taken, and has he skipped the medications that you have asked to skip. Check the consent, most importantly. Then you can have a look at his vitals. Check again for any new symptoms like cough, cold, auscultate ones. Check the NPO status as well. Okay, so this is basically how you check the patient before you're going to wheel him in to the OT. So once you take him into the OT, you attach the monitors. What monitors do you need? So the minimum monitors that you'll need are an ECG. 3-lead ECG is good. If you have a 5-lead ECG, that's better. We usually monitor lead 2, which is the rhythm strip. You can see the P waves well, and you can identify the QRS in the classical way. So you can identify arrhythmias very well in that. And then we usually have on the monitor a chest lead as well. So that depends on where you want to monitor the most. So apex, so V5, if you keep it around V5, you monitor the apex. It is said to identify ischemia very early. But if you have anterior wall ischemic focuses, then for example, you can monitor V1 or V2 as well. So there's no hard and fast rule. So it depends on the patient. Then you need a pulse oximeter that shows you the saturation, important to monitor, and it as well shows the heart rate. And if you have the facility, it will show you the waveforms through which you can have other parameters like pulse pressure variation. And looking at the waveform itself, you can have an idea of the pulse thrust, as they would describe it in the olden days. That is the volume of the pulse. Then you need monitoring of BP, because a lot of the agents that we use, they cause hypotension. The surgical responses cause hypertension, as well as the patient might be unstable. So you require a minimum of non-invasive blood pressure monitoring. You can tie it in the arm or you can tie it in the leg. In certain cases, you might require invasive beat-to-beat BP recording. So that would be arterial BP in the radial arterial line or in the femoral arterial line, dorsalis pedis arterial line. It depends on the situation. Central venous pressure monitoring in some cases, right? Not always. Other monitors would be, in certain cases like cardiac surgeries, you would require an esophageal echocardiography, right? Transesophageal echocardiography. Like some cases, like spine cases, you might have other monitors as well, like sensory evoke potential. So these are the monitors that you'll attach. Then comes the IV axis. IV axis is very important to the anesthetist because that is our gateway for intervention, right? Anything that happens, we'll have to give drugs through IV. So you'll have to secure a decent IV. It depends on the surgery. If there is a lot of blood loss anticipated, then you'll require 2 wide bore IV cannulae, that is 16 gauge or above, 14 gauge, 16 gauge, with a decent flow. Then you'd start pre-oxygenation. So pre-oxygenation is to be done for 3 minutes. Again, if it is a healthy ASA physical status 1 patient, young patient, then you don't always have to do it that meticulously. You don't always have to do it that religiously, but for patients with poor cardiopulmonary reserve, difficult airways where you anticipate some apnea period, all these cases you will have to do 3 minutes of pre-oxygenation. That is, you keep a mask, create a decent seal, and give 100% oxygen for 3 minutes. Again, if there is no time for it, so within a span of 30 seconds, if the patient is able to have 4 good vital capacity breaths or 8 good breaths in a span of 1 minute, so this is also sufficient. So pre-oxygenation is supposed to remove all the nitrogen from the lung, thus filling the alveoli with pure oxygen. So this is the idea, to increase the apnea period. They say up to 8 minutes of apnea can be tolerated without the patient going into hypoxia. So now we start the drugs. So we keep in mind 4 components of general anesthesia. So first one is analgesia. So intubation and surgical interventions, these are all painful. So you will have to take care of the pain. So that is analgesia, for which we will use drugs like opioids or NSAIDs, to a certain extent. So, some IV induction agents as well, like ketamine, right? Inhalational gases like nitrous oxide, all these have analgesic property. So analgesia is to be taken care of. Then comes sedation. So the patient might have to be placed in awkward positions for a long period of time. Patient will be paralyzed. So if the patient is awake, it will be a terrible experience. So to avoid all that, we will have to sedate the patient. That is to make him sleep, basically. So that is sedation. For that, we have IV induction agent like propofol, thiopentone, ketamine, midazolam, etomidate. That's the sedation part. Then there is amnesia. So whatever experiences the patient has intra-op, you don't want the patient to remember it, because that is usually a traumatic experience. So you're better off without the memory of them. Amnesia is another important component of anesthesia. Then there is muscle paralysis. Muscle paralysis helps the anesthetist, it helps the surgeon as well. It helps the anesthetist because the patient patient doesn't resist the ventilator, and so you are able to control the ventilation. And it helps the surgeon in many surgeries, like the abdominal surgery, when the abdominal muscles are relaxed. They are able to operate better, they are able to retract better. Orthopedic surgeries, they are able to manipulate better without the muscles giving traction. So for each of these we use agents. After we pre-oxygenate, we induce with IV induction agents like propofol or etomidate, depending on the case, looking at the hemodynamic parameters. It's best to give titrated doses, but anyway, if you're going to use propofol, which is commonly used, 2 to 3 milligrams per kg is the dose. You would also like to improve the depth of anesthesia, provide analgesia simultaneously with opioids like fentanyl. Fentanyl can be used as 1 to 2 micrograms per kg. Then you check for bag and mask ventilation, right? Because the next step is going to be paralysis, muscle paralysis. So you don't want to end up in a situation where you have given paralyzing agent, but you're not able to ventilate. Then patient won't be able to breathe, right? So check for bag and mask ventilation, and then give muscle paralysis. So depending on the depending on the paralyzing agent or the muscle relaxant that you've given, you'll have to wait before you can intubate. So if you have given vecuronium, it takes like around 3 minutes for it to completely act. If you have given atracurium, for example, so it will take around 4 minutes. If you have given scolin, then it will take 45 to 90 seconds actually, if you have given scolin. So you'll have to wait for it to act. In the meantime, you cannot sit for 3 minutes and for 4 minutes when the patient is not breathing, so you'll have to ventilate. You can simultaneously deepen the plane of anesthesia with inhalational agents. Give it time to build on over 3 minutes or 4 minutes, whatever it is. So it gradually picks up in the alveoli, in the bloodstream, and in the brain. Right. So at the end of 3 minutes or at the end of 4 minutes, whatever it may be, you position the patient well. That is, there should be flexion of the cervical spine and extension of the atlantoaxial joint. Right. Give a good mouth opening. Introduce your scope. Push the tongue to the side. Visualize the vocal cords and intubate. Fix the tube at the appropriate length. Auscultate once you have fixed it, once you have secured it, to know the position that it's bilateral, bilateral air entry is there, and then fix the tube. Now, maintenance of anesthesia would be with a combination. Pure oxygen isn't usually given. You're going to give oxygen plus air, maybe, oxygen plus nitrous oxide is another combination. Typically, at a flow rate of, fresh gases around 2 liters. There is another way of giving it called low flow anesthesia, wherein less than 1 liter is given. For that, you have to have good circuit, and carbon dioxide absorbent should be well. You must have monitoring for capnography, for end-tidal carbon dioxide, as well as the inspired carbon dioxide, to know if there is any recirculation of the carbon dioxide. So a combination of these two with volatile anesthetic, be it isoflurane or sevoflurane or desflurane, whatever it may be, halothane. So with this, you're going to put on the ventilator. You can do bag and mask, but for longer surgeries, you're going to put on the ventilator. You set the tidal volumes, you set the rate, you set the PEEP, look at the FiO2. You can adjust the flows and set the FiO2s. And if you have a gas analysis apparatus, then it's very good, because it can show you not just the capnography, but it can show you, the mixture of gases that are inhaled as well as exhaled. So it will as well calculate the MAC, which is very useful. So throughout the surgery, you'll have to take care of these parameters, right? Analgesia, sedation, so amnesia as well, and muscle paralysis. Volume. So how are you going to set the tidal volumes? 6 to 8 ml per kg. So that's how you're going to set the tidal volumes. And a respiratory rate of maybe 12 to 16. You can go up to 20, depending on the situation. Also make sure that the peak pressures are less than 35, the plateau pressures less than 30, to prevent barotrauma or volutrauma. What other things are you going to see in the surgery? You are going to look at the surgery, look at the steps of the surgery, and assist in certain things that the surgeon might need. So adequate relaxation in certain surgeries. So Valsalva maneuvers sometimes. Looking at the BP and controlling the BP. Right? So these are the things you're going to see. Then you're going to monitor the vitals. That is very important, because hemodynamic fluctuations are very common. This is a daily occurrence for an anesthetist. So close monitoring of the vitals and repeated BP monitoring. At least every 5 minutes is what is recommended of NIBP. If you have beat to beat recording of the blood pressure, then that's very good. Then you're going to look for blood loss, right? If the patient is catheterized, if it is a short surgery, patient might not be catheterized. Otherwise, if the patient is catheterized, you're going to monitor the urine output, right? So this is an indication of perfusion. So adequacy of the BP or the adequacy of the fluids that you have given. So minimum of 0.5 ml per kg per hour of the urine output you're going to see. So hourly urine output and Constant lookout for blood loss and measurement of blood loss in the mops, in the suction, in the drapes, right? So these are the sources where you can lose blood into. And calculate the maximum allowable blood loss, and if you feel that the patient is going to cross that, you'll have to supplement it with blood. Then you're going to do fluid management. So in pediatrics it is Penlington's formula you can follow, or in the adults you're going to an easy formula is twice the body weight. This will be the ml of maintenance, and then you're going to make up for the deficit, right? You're going to calculate the blood loss and then make up for it as well, third space loss. So all this you're going to calculate and give the fluids appropriately. Look at the vitals, right? Look for signs of fluid loss, and then temperature. So you can have a temperature probe to monitor the temperature, especially in long cases. If you're if there's a lot of blood loss and you're going to give a lot of fluids, there might be rapid loss of temperature. At the end of surgery, you're going to make sure that the relaxant has not been repeated in the for example, in the last half an hour for vecuronium, or at least 20 minutes for atracurium, because that is the safety period for you to ensure there is no residual neuromuscular paralysis in the post-op after you've given the reversal. Okay. Then you will cut off the agents, right? Put the patient on 100% oxygen, suction well, suction all the secretions. You can put an oral airway to aid in this process. You can put the patient on bag and watch for respiration, and until the respiratory efforts are there, you can ventilate yourself. Once the respiratory efforts are there, you can give reversal. So neostigmin with a combination of neostigmin with glycopyrrolate is an example. Then you're going to, once the spontaneous efforts are there and you've given the reversal, you're going to closely monitor the respiration. You're going to closely monitor the tidal volumes and the respiratory rate. Whenever inadequate, you're going to assist until the tidal volumes are at least 4 ml per kg, and respiratory rate is more than 12, right? Not tachypnic either, but regular respiratory rate with good volumes. Then you're going to wait for the agents to wash off, that is the inhalational agents to wash off, and make sure that they're completely washed off. Patient is opening the eyes, is obeying your command, is able to, there are certain tests to identify adequate reversal. So one of it would be the 5-second head raise or 5-second hand raise. If the patient is able to do that, the patient is obeying your commands. Ask the patient to protrude the tongue. If the patient is able to do that, then you're going to do a repeat suction again gently, and then you're going to loosen the plasters with a positive PEEP. With some positive pressure, you're going to remove the tube out. Put the mask back on, put the face mask on, observe with 100% oxygen for a while, observe the respiration. Take the mask out, observe the respiration, observe for saturation. Right, if the patient's saturation is maintaining on room air, then you can shift the patient. Your job is not done. Of course, in the post-op, you're going to attach all the monitors back again, BP, the saturation probe, and the ECG. Monitor the patient until the patient is shiftable to the ward. That's it for today, guys. Have a nice day.